kind of newish content looking at different aspects of it. All right. So we now classify obesity as a disease process. It's really one of the biggest epidemics of our century. There's a significant amount of the population worldwide that's defined as obese, overweight and obese as well. About a third of Americans are classified as overweight or obese. And I think if you look at the number of patients and our patients specifically that we interact with, it's probably closer to 60 to 80% of patients qualify as overweight or obese. As far as being defined as a preventable death, it is second only behind smoking. But with that being said, there are a lot of factors that kind of come into play as far as why patients wind up being overweight or obese. And we're really starting to explore some of those now, which I think will make a pretty big difference in the future. Big ones we look at, metabolic factors being one that we have some degree of control over. Hormonal processes, again, we have some degree of control over, just as they're kind of tied into metabolic factors. I think when we go back and we start looking more and more at genetic factors, they're really going to tie into those two things. We have, again, some degree of control over our neural regulation, and our pathologic syndromes are generally as a result of obesity, but there are a small percentage of the population that has obesity as a result of their underlying syndromes. But I think the big ones here that we really kind of tie into are really our behavioral, cultural, and our socioeconomic factors. If you go back and look at what we were providing to low-income families and still provide to this day, as far as, quote, nutrition, it's anything but it was high-calorie foods that could be stored and preserved for long periods of time. The downside of that is that all those foods are high in sodium. You wind up with hypertension, diabetes, and it turns into a vicious cycle. Very rarely do you go to any sort of low-income food supplier and they're passing out fresh fruit and vegetables, things that are really healthy for people to eat. So I think our society is to some degree at fault for that. Part of it's a knowledge deficit as well. People don't understand how they're cooking and, what they're cooking that causes bad things to happen. And then being able to address any of those factors in moderation, I think, is problematic. Over time, I think we've made some changes, but I think the changes we've made have been away from like what I consider real food into more junk type stuff. As our societies become more portable, we look at food on the go, not food that's home cooked. It's more fast food meals, or even if you buy, like carry out meals from the store, they tend to be a lot higher in bad things than what we would make on our own. But there's that. BMI is kind of the most widely applied tool to evaluate body mass index. It was originally developed by insurance companies as a means to classify patients according to their risk. There are some problems for calculating or for BMI, but one thing I would make sure you know how to do is calculate BMI itself, and it's just weight in kilograms divided by the height in meters. Now, with that being said, the problems you run into with BMI, it doesn't account for any sort of weight balance. Weight is weight. So if you have 100 pounds of muscle, it's seen as 100 pounds of fat. They're equivalent. There are some scales out there, and I think the one I saw that was the most accurate as far as health impact the other day was neck ratio to waist ratio. So I think that might be, in the future, something that we look at as healthcare providers as opposed to what the insurance companies are looking at. But that's neither here nor there. You generally see two different distributions of fat. You have kind of android or like truncal obesity. So these are people that are overweight in their upper body primarily. And what we see from a health standpoint as a result of that is they're associated with increased oxygen consumption and cardiovascular disease. And then the other was kind of gynecoid or peripheral obesity. So if you think of like pear shape versus apple shape, these are people that tend to have a little bit more fat like on their lower body, hips, butt, and thighs. They tend to be a little bit less metabolically active. And the nice thing for them is it tends to not be so much associated with cardiovascular disease and more of a genetic component as opposed to android obesity that tends to be associated with CV. So what do we see in the cardiac system as a result of obesity? Because you have an overall increase in surface and body habitus, you have an increase in your total blood volume. But with that being said, most of that blood volume is distributed out through the adipose tissue, so it may not be really well effectively circulating. Because of that increased volume, you tend to see an increase in cardiac output, and because of that, you tend to see an increase in the left ventricular mass and dilation, as well as the stroke volume, which kind of makes sense. Somehow, if you've got more body tissue, you've got to perfuse it, so you're going to have an increase in heart rate and increase in stroke volume. You also tend to see an increase in cardiac dysrhythmias, which makes sense. We talked about them having an increase in cardiovascular disease processes, but they also have fatty infiltrates throughout their entire vascular system, so coronaries as well as peripheral vascular system as well. You tend to see a decrease in your QRS voltage because of the increased impedance between where you're measuring and where the heart is. So when you're looking at somebody that's a little bit larger, you may see that the EKG waveform is significantly smaller. You may have to go into the machine itself and see about increasing the size. So for example, sometimes if you're monitoring a large patient in the operating room, you may just go to your monitor and increase the QRS size from 1x to 2x to 3x to what have you. From hematologic factors, you tend to see an increase in level of a lot of the clotting systems. So they tend to be hypercoagulable. As a result of that, it's like the perfect storm. You've got somebody that's already got cardiovascular disease, so they've got all these fatty deposits, and then they tend to clot a little bit easier. So it tends to lead to poor perfusion in the extremities, increased risk of DVT, as well as arterial vascular disease. You also see a high level of endothelial dysfunction in those patients due to the increased levels of factor VIII and von Willebrand's factor. As these patients get a little bit older, almost all of them are going to start off on some degree of anticoagulation. Usually it's going to be baby aspirin, and then they quickly move on to something a little bit stronger. So one thing for you to think about when you start looking at overweight or obese patients is figuring out what anticoagulants they're on, and kind of where they're at in their disease process. GI patients, and we're going to talk about this a little bit more as we get to some of the medications. Their gastric volume and the acidity are already increased. They have a delayed gastric emptying without even accounting for diabetes or any of the diseases that tend to follow obesity. So expect an increase in gastric volume. One of the things we really have to be cautious about in these patients and patients in general, if you have somebody that's retained about more than 25 mLs of fluid and very acidotic fluid, so think like a pH less than 2.5, that's where we really worry about those patients aspirating that fluid and developing a pneumonitis. Lower volumes or higher pHs tend to be less problematic, but that's kind of like the perfect storm. You get more than about 25 mLs, which isn't very much. And that very acidotic fluid, it's kind of a bad recipe for patients when they aspirate. You tend to see a decrease in their hepatic function. They also tend to have decreased levels of albumin in circulation. So when you think about wound healing in this overweight diabetic patient, and then they don't have enough albumin, again, kind of a bad setup for that patient. Due to the increased abdominal volume, you tend to see an increase in the pressure on the stomach itself. So you may notice that they develop kind of a stretch or a relaxation of their lower esophageal sphincter, and there's an increased rate of formation of hiatal hernias in this population as well. From the kidney standpoint, you tend to have an increase in the renal blood flow for a time, but at some point in there, their disease process catches up, and either as a result of the hypertension or the hypercoagulable state, they tend to have a pretty significant drop-off in their renal blood flow as their kidneys begin to not perfuse so well. You also generally will see a little bit of an increased renal tubular reabsorption, but again, it drops off pretty quickly. From an endocrine standpoint, as I kind of touched on, you tend to see impaired glucose metabolism in this patient population, resulting in insulin resistance. You also tend to see that they have an enhanced activity of their norepinephrine and angiotensin receptors. They have high sodium levels, which feeds back into their high blood pressure, and then their kidney disease and their diabetes and everything else. And you also see a very high level of hypothyroidism in morbidly obese patients. It's kind of interesting. Some of these patient populations, when they go on Synthroid or any of the other thyroid medications, that alone is catalyst for weight loss. So if you start looking at patients, or even just your friends, if you see somebody that has either a significant weight gain or a significant weight loss in a short period of time, think that there may be some degree of endocrine involvement. So for instance, like if you have somebody that's obese and then they have a significant weight loss, I would be concerned, or think that perhaps they had a thyroid issue and then they went on medication, or more concerning that they have diabetes that hasn't been diagnosed yet. So just think about things like that in that patient population. And then I also worry about metastatic disease when somebody has a pretty significant weight loss that wasn't really planned. These are some disease processes that are commonly associated, and it's almost like a little Venn diagram. You'll notice that there's a lot of overlap and interdevelopment between these disease processes. So they have hypertension, they have diabetes, then those two kind of contribute to their cardiovascular disease. They're overweight, maybe they're insulin resistant, and then they start developing osteoarthritis. So then they start taking, whatever, ibuprofen, any of those simple things to try and help out their osteoarthritis. And the next thing you know, they've got ulcers on top of their impaired gastric emptying, which is compounded by the fact that the gastric acid is already too high and the pH is too low. So it very quickly turns into a vicious cycle for a lot of these disease processes. So kind of the combination you'll see is that they're overweight, they're diabetic, and they're hypertensive. And then now pretty commonly you can add sleep apnea to that as well. And then usually like stuff like asthma and COPD is due to an outlying cause. Asthma may be environmental or genetic. COPD is usually due to smoking. Not all the time, but in that same patient population, you've got somebody that was already high risk for vascular stuff and now they're smoking. It's just not a very good combination for those patients, or anybody else for that matter. So we started off, we used to just kind of assume people were overweight. Now we've kind of developed a pre-diabetic diagnosis, which we call metabolic syndrome. It's a cluster of a couple different things, a lot of what we just talked about. So you see these patients tend to be abdominally obese. They have low HDL levels. Their triglycerides are very high. They tend to be hyperinsulinemic. They have an intolerance to glucose. They become hypertensive. They tend to have that pro-inflammatory and pro-thrombotic state. It says only 3 for diagnosis of it, but a lot of times when you look, you'll see that these patients have like 5 or 6 of them. It's not like onesies and twosies. By the time they're diagnosed, they usually have a lot of this in place. So if you see metabolic syndrome, this is what it's referring to. It's not talking about them being acidotic or something to that effect. Think about it as kind of your diabetic trifecta of hypertension, obesity, and diabetes. One of the nice things is that it uses actual waist circumference as kind of the measurement for it as opposed to BMI. So you help kind of rule out those people that are just muscular. Associated risk factors, increased age tends to occur in men more than women. And it tends to occur more often in minorities, specifically Hispanics and South Asians, than Caucasians. Reasons it may happen of a non kind of diabetic trifecta: chronic corticosteroid use, antidepressants, antipsychotics, and protease inhibitors. One of the things we really worry about and why we're trying to take care of it as soon as possible, and it will kind of tie into what we're going to talk about a little bit later as far as medication. If we don't treat this when it's at the metabolic syndrome stage, it progresses pretty quickly, and those patients will develop the cardiovascular disease, the diabetes. 2 things that we're starting to recognize more and more as being really contributing factors or outcomes of this is polycystic ovarian syndrome and then non-alcoholic fatty liver disease, or NASH. Those were 2 things we didn't really think about before, and people would develop liver issues and we didn't really understand it. We just, chalked it up to they had a fatty liver. And now we're starting to understand a little bit earlier on, if we can capture these things and start treating it earlier, that they tend to do better. As a result of this, they have kind of weird immune responses. And what I mean by that is they get sick, but when any normal healthy person would be able to fight off something like a cold, they tend to do very poorly. I think this is one of the patient populations that did very poorly with COVID because of a lot of these factors. They just didn't have that adequate immune response. When you went back and looked at what we would call otherwise healthy people, you started figuring out that they already had this metabolic syndrome developing. They were a little bit overweight. They were either diabetic or pre-diabetic. They had a little touch of hypertension. After you think about like the really sick people that didn't do well with COVID, I think this metabolic syndrome group is the ones that really struggled. The good news for this patient population is that almost all of these symptoms, almost 100%, which is pretty high for anything in healthcare, will resolve with loss of weight and bariatric surgery, or bariatric surgery leading to loss of weight. With some of the medications we're going to talk about in a little bit, they may be able to lose weight without having bariatric surgery, which used to be the only alternative for those patients. One of the other complications we tend to see associated with obesity is obstructive sleep apnea and hypoapnea syndrome. So obstructive sleep apnea means you actually stop breathing. It has to last longer than about 10 seconds or more, and it has to happen more than 5 times an hour during sleep. And during that time, the oxygen saturation has to decrease by about 4%. We'll talk a little bit about the sleep study, but that's how all these things are diagnosed. Formally, as someone goes in for a sleep study, and they actually monitor them. They do EEGs. They keep on them continuous pulse oximetry. They're audio-visual recorded. And from that perspective, they're able to actually capture all these events and see what happens. Unscientifically, we can ask patients' partners, someone they sleep around. I can tell you back when I was in the fire service that, we were in a bunk room with like 8 or 10 people. You knew who snored. You knew who wasn't breathing anymore. So it's pretty obvious when you're around people. You just have to pay attention. Now, we didn't count it or any of those sorts of formal things, but you knew what was going on. And that was before it was really kind of a predominant syndrome. Hypopnea is a reduction in the airflow of greater than or equal to 50% for 10 seconds. So think about somebody that's still breathing, but their volume is dropping off pretty precipitously. Same kind of basic criteria. It lasts more than 10 seconds. It tends to happen a little bit more frequently, but we're talking about one breath here, not a whole period of apnea. So generally more than about 15 times during an hour of sleep. And again, it results in a decrease in their oxygen saturation. So diagnostic-wise, like I said, these patients are going to have a sleep study done. And I will tell you from an anesthesia standpoint, we don't do anything with sleep studies, but probably because of the associated risk factors for a lot of these patients, I've gone to like so many codes in the sleep lab, which are like the least medically trained people in the hospital. So just think about that when you're figuring out the lay of the land for the hospital. So this is just kind of a list of criteria, or kind of how they quantify these apneic and hypopneic periods. Mild is 5 to 15 episodes an hour, moderate 15 to 30 episodes an hour, severe more than 30 episodes an hour. So if you think about somebody that's becoming apneic for more than 30 times for more than 10 seconds, that's a lot of time you're not breathing during an hour. So primary treatment is aimed at modification of lifestyle, so weight loss. Temporizing treatment is usually some sort of airway pressure support, to like CPAP. If not, what you'll see in these patients is they tend to develop not only systemic but pulmonary hypertension as well, left ventricular hypertrophy, and they're also at risk of cardiac dysrhythmias. And then one of the big things here, we say cognitive impairment. That's more of like a long-term thing. Think about the short-term effects you're seeing of somebody that's not well rested. I know you guys are going through a period in life right now where you're not really as well rested as you'd like to be, but imagine that's every day for somebody. You can see how quickly their cognitive level and their functional level would drop off without adequate sleep. Something else we see is obesity hypoventilation syndrome. It's also known as Pickwickian syndrome. It's one of those cool names that people like to stick on tests. But this is patients that have had sleep apnea for a long period of time. A significant number of them are going to be super morbidly obese. And what you see is this is kind of the end result. So those patients had sleep apnea, they didn't get treatment, they'd already developed like pulmonary hypertension, and ultimately it kind of leads on to cor pulmonale. Diagnostics is based off of elevated BMI, but the biggest thing is the awake hypercapnia. So these are the people you're sitting here talking to them and they're wide awake, but their, SATs may or may not be affected. But if you happen to get a continuous capnography, you're going to see their CO2 is 50, 60, 70. And when I say wide awake, it's wide awake for them because they do tend to have like somnolent periods while you're actively talking to them. So just something for you to be aware of. So treatment for these patients, originally it was targeted at weight loss surgery, whether it's through gastric sleeve, bypass, what have you, Roux-en-Y bypass. After that, we kind of transitioned to medical therapy. You do still see a lot of bariatric surgery being done, but as a society, we're always looking for kind of like the quicker thing or the next best thing or the easy thing. So we started off with phentermine. It's a sympathomimetic which decreased appetite. It was FDA approved, but only for a short period of time. Side effects of it, tachycardia, palpitations, hypertension, patients became dependent on it. And then they would also start to abuse it just like anything else. So you would see that patients lost weight, and as they took the dosage they were prescribed and lost weight, they wanted to start taking more because they felt like that would help them lose weight faster. It may have worked, it may not have. When it was originally prescribed, there was a combination of phentermine and fenfluramine. It was called fen-phen at the time, which resulted in a lot of valvular disorders. So the fenfluramine component was pulled off the market. You will still see phentermine used by a large number of people. It's probably decreased now with some of the GLP-1 agonists out there, but there is a significant number of patients that take phentermine. From our standpoint, one thing you have to be very cautious about in this patient population is they tend to have profound hypotension and bradycardia and may not respond very well to any of our traditional blood pressure medications. So usually if somebody is coming in for elective surgery, we'll take them off their phentermine for about 2 weeks. Orlistat, I forget what there's a couple of different kind of trade names out there for it, but basically Orlistat works by blocking the absorption of the dietary fat. So what happens with the patients is they start developing these liquidy stools that are very oily, and they may happen very quickly. So I've heard of patients that had no chance to go anywhere near the bathroom, and it's almost to the point of incontinence. You'll also see there's a high degree of like abdominal cramping in this patient population. Over time, patients will develop some vitamin deficiencies, not only with this, but with a lot of these different medications. So it's very important that they're doing some sort of vitamin supplementation to try and keep those levels up. One of the biggest ones we worry about in the Orlistat population is a vitamin K deficiency, so they may not clot properly. There's also a wide variety of over-the-counter herbal medications out there. Some like caffeine and green tea come with their own set of ill effects. You may see some that are targeted more at like appetite suppressants, like ginseng, sunflower oil, ephedra. Although I think it's pretty hard to find ephedra now. Energy stimulants out there. Ephedra was really like one of the big energy stimulants several years ago, but because young healthy people were having cardiac events, it was mostly withdrawn from the market. There's still some out there, kind of off-label or harder to find formulations, but there's not a whole lot of ephedra out there right now. And then there's a couple others that work to kind of regulate lipid metabolism. You'll see a lot of the fish oils and like soybean oils are pretty popular. And I think when you start looking at some of this stuff, a big takeaway for us is to recognize the role of kind of non-medication medications that may affect things. So just because it's not something prescription doesn't mean it's going to not affect our patients. So moving on to kind of the latest and greatest craze, GLP-1 agonist, and they're approved by the FDA for treatment of type 2 diabetes and cardiovascular risk reduction in diabetic patients. That's the actual FDA approval. With that being said, they were being used off-label and are really being used off-label now for weight loss. The problem we run into in this patient population is that it tends to result in delayed gastric emptying. So these patients will have so you think about it, they were probably already overweight. They may potentially be diabetic. So both those things result in delayed gastric emptying. And now we're giving them a medication that's going to further compound their delayed gastric emptying. So you're kind of setting yourself up to have an aspiration type situation on top of somebody that, maybe already has increased acidity, increased volume. So potentially a very bad aspiration pneumonia. Most of these medications are administered by a subcutaneous injection, usually once a week. There are some exceptions, but I've got a little chart here. I wouldn't worry about so much memorizing like the dosage and how often. I would make sure you knew that like these medications, like if somebody says semaglutide, that they're talking about one of these GLP-1 inhibitors. Almost all these medications, like I said, are going to be a sub-Q injection once a week. Some of them are daily sub-Q injections, but when you take a look at all the things that are coming out of these medications, one, there is weight loss, which is good. And with the weight loss, you tend to see a lot of healthy effects: decrease in hemoglobin A1C, decrease in their blood pressure. So as you compare this to potentially a patient having to go under a surgical procedure for whatever bariatric procedure they're having done, this may be a much better option. I don't know that we have enough data at this point to really think about long-term complications. From a short-term effect, one of the biggest things we worry about right now is that some of the medications do have an increased risk of pancreatitis. Some of the medications have a risk of hypoglycemia as well, which kind of makes sense. But the biggest stuff we're seeing is kind of GI type symptoms: nausea, vomiting, diarrhea, headache, constipation. So kind of relatively minor side effects. I think if you can take these and lose a lot of weight, especially if it gets you back in kind of a healthy range, it's probably not a bad thing. But we're seeing a lot of patients that are taking these medications right now. So from an anesthesia standpoint, things to kind of think about. If you've got somebody that's taking these medications, like I said, consider having them stop at about a week out. For us, it doesn't really matter whether they're taking it for diabetes or taking it for weight loss, or what type of surgery they're having done. We're more concerned about our effects of things. Now, of course, the ASA put out the recommendation to hold it for a week, and then the GI docs turned around and said, no, it doesn't really matter, which is kind of funny considering they're the ones doing scopes on patients usually without secured airways, and then they're insufflating, and those patients are already at a higher risk for aspiration. So there is some degree of conflict as far as what the recommendations are, and we'll talk a little bit in a second about how we can kind of evaluate that and things we can do to figure out how to maximize our patients for that day of surgery. Other things you have to think about if you have this patient that's taking this for their diabetes, if you're going to stop this medication, they probably need something else for glycemic control in the time between when they stop and when they get to the operating room. So talk to the patient's PCP or endocrinologist as far as what they can do in that time period. So the day of the procedure, if you have somebody that shows up with those GI symptoms we talked about, nausea, vomiting, abdominal pain, constipation, I would strongly consider delaying the case that day because of the risk of aspiration at that point. If they've done everything we ask and they seem asymptomatic, you're probably fine to go ahead and proceed. If you have somebody that seems to be asymptomatic, but they didn't follow your recommendations to stop, go ahead and proceed, assuming they're a full stomach patient. So consider like an RSI. Or the other thing you can do at that point is use the ultrasound to evaluate their gastric volume. And we're going to watch just kind of a quick video here in a minute to help you guys out with that. Because I think that's something we're going to start to see more and more of in clinical practice, is us not only having to do ultrasound, or not having to do, but not doing just ultrasound for peripheral nerve blocks, vascular access, echocardiography. I think we're going to see it branch out into stuff like gastric scanning for abdominal contents. And then just one more thing before we get on to the gastric scanning video. Just because you don't see any contents in the stomach itself doesn't mean there aren't contents other places in the gastric system. So for instance, you think about somebody that's got a bowel obstruction. Their stomach may be entirely empty, but because of that obstruction, they still have the potential to regurgitate those contents. Because of the delayed gastric emptying you see in this patient population and the decreased peristalsis, there's still an increased risk of aspiration, even if your gastric ultrasound is negative. But with that being said, it's really about the best screening tool we have at this point. All right, I'm gonna switch screens real quick and let you guys watch this. I think it's a pretty good overview of stuff as far as gastric scanning techniques. You guys able to see that?
Yeah, we can see it.
Okay, cool.
Hello, my name is Rachel Douglas. I'm a regional anesthesia fellow at the Mayo Clinic in Rochester, Minnesota. I wanted to share with you today my presentation on gastric ultrasound. We are going to approach the information today with the IM framework. This is how this material was first presented by Dr. Anahi Perlis. She is best likened as the godmother of gastric ultrasound. My presentation today is based upon her research and material found on her website, gastricultrasound.org. First, we are going to start off with the indication of gastric ultrasound, and then we will move on to how to acquire the image, then how to interpret the image, and finally, how to apply our assessment to best medically manage our patients. So what are the indications for gastric ultrasound? It is really to assess the patient when there is an unclear prandial state. Most commonly, that may be when there is a trauma patient. There may be a language barrier or altered mental status of a patient. Also, we all have had a child coming in for surgery, and there is a question as to whether or not they are truly NPO. Also, you may have a patient who has morbidities that slow down gastric emptying, or you may want to verify NG tube placement. One of the biggest pushes to learn gastric ultrasound at my institution is the recent prevalence of patients taking GLP-1 agonists such as Ozempic. These medications are known to slow down gastric emptying in this class of patients. We are finding that patients on GLP-1 agonists may not truly be an empty stomach when presenting for elective surgery despite following the NPO guidelines. So what materials do we need? Just an ultrasound and the appropriate probe. We use a curvilinear or phased array probe for adults, or if you have a child underneath 40 kilograms, you can use a linear probe.
Ready to start eating healthier? Meet Kachava. Kachava is the world's healthiest.
To acquire the image, you find the xiphoid process with one hand and place the probe just distal to that. The probe should be oriented in the sagittal plane with the orientation marker pointed cephalad. For gastric ultrasound, we assess the gastric volume and contents in both supine and the right lateral to cubitus positions. This is the image that you should see. What we can appreciate in this image is the liver cephalad, the antrum just distal to the liver. It has the A over it, and just deep to the antrum is the pancreas. Deep to the pancreas is the superior mesenteric artery, and deep to that is the aorta. For gastric ultrasound, all of the assessments are to be performed at the antrum of the stomach. We know we are at the antrum when you see the stomach, the pancreas, the SMA, and the aorta all in the same image. You may have to slide your probe parasagittally to get the alignment of these structures in the same frame. It is imperative that you prevent having an oblique cut of the antrum by keeping your probe perpendicular to the surface of the skin. Now that we have verified we're at the antrum, we can assess the appearance of the gastric antrum. Gastric ultrasound is first based off of qualitative assessment. So we're going to work on developing pattern recognition. Here we have an empty antrum. It is small, collapsed, and has the appearance of a bullseye. The bullseye pattern is from the 5 alternating layers of the gastric wall. Here we have a full stomach. We know that this patient recently ate because the solid material and air intake while the patient was eating is preventing the ultrasound beam from penetrating deeper into the abdomen. So we have the frosted glass pattern as appreciated by the white line that fades into the black dropout on the ultrasound screen. The antrum also appears distended with thin walls. Here we have a patient that ate a few hours ago. The stomach looks larger as compared to the empty antrum we saw earlier, and there is not the black inner marking appreciated on the bullseye pattern from an empty antrum. Instead, we see a fuller, more distended antrum that has a heterogeneous mix of contents. The hyperechoic specules are most likely small residual air bubbles or fat. Of note, as the food has digested, much of the air has escaped that obscures our view immediately after ingestion. Therefore, on the later stage of food intake, the ultrasound beam is better conducted and we see the deeper abdominal contents. Here we can verify that we are at the antrum because we see the pancreas, SMA, and the aorta. Here we see an antrum with only clear liquid. How do we know that? Well, we appreciate that with what we call the Starry, Starry Night pattern, named after Vincent van Gogh's painting. The antrum is distended with clear liquid, which appears dark or hypoechoic on ultrasound. The speculated white hyperechoic dots are air bubbles. That air came from either when the patient was swallowing while drinking, or they drank an effervescent liquid such as bubbly water. And here we see the homogeneous, dark, hypoechoic appearance of clear liquid without any air. It's natural for your stomach to create clear gastric fluid. As a physician, we need to discern, is this clear liquid just naturally produced gastric fluid, or is this someone who recently drank a significant amount of clear liquids? This is where we get into the clinical application of our assessment. To make the clinical application easy, we're going to break things into qualitative and quantitative assessments. I'm going to start with a quick and easy qualitative assessment. Of note, this flow chart on the right is for when the patient is in right lateral decubitus position. Okay, so if the patient is starting out supine and you see a stomach full of solids or clear liquids, you are done. The patient should be considered a high aspiration risk. However, if you look and see the bullseye pattern suggested on an empty antrum when supine, then you need to turn the patient into the right lateral decubitus position. If you see the bullseye in right lateral decubitus and supine, then you can be assured the patient has an empty antrum. We qualify this as a grade 0 or low aspiration risk. However, if you only see clear liquids when the patient is in right lateral decubitus position and you did not see those clear liquids when the patient was supine, the liquid contents are considered to be less than 1.5 mLs per kilo, which is consistent with naturally occurring gastric juices. They would be considered a grade 1 or low risk patient. For quick clinical assessment, the aforementioned qualitative assessment method should work. However, if you're doing research or second guessing yourself, you can do a quantitative assessment. So Dr. Perlis and her team came up with this chart for assessing gastric volume based on the calculated gastric antrum area and the patient age. The measurement is only reliable if the patient is in the right lateral decubitus position. You would calculate the gastric area using the trace tool on the ultrasound machine and then
I think you're muted.
right of the screen.
Thank you. I don't know how that happened.
The trace option
I didn't
will
touch it.
appear. Click that. Then you will see the drag.
And you know, Dr. Cornelius, the video's frozen too. We haven't been able to see it the whole time.
The gastric.
Oh. Let me see if I can figure out why.
Antrum, making sure that
Can you guys see it now?
include the hypoechoic ring around the stomach, as this is the gastric wall.
Yeah.
Okay.
Yes.
Sorry about
And
that.
then finally, an area will appear, and you use that to discern the volume using Dr. Perlis's chart. To find the gastric antrum area on the sonocyte LX, you first hit the snowflake icon to freeze the picture. Then you hit the caliper button. You'll then get this screen and you want to click the trace button. And then as before...
Yeah, I think it's still frozen. It froze once you hit the full screen button.
Okay, I will take it off full screen then. Can you guys see it now?
Yeah, we can see it now.
Okay, we'll just leave it there then.
And then you will get a calculated area and you refer to Dr. Perlis's chart. So here are some quick clinical pearls. If you're looking for the gastric antrum and feel a little lost, the antrum is always immediately distal to the liver. If you look in the supine position and the antrum appears full of heterogeneous solids or clear liquids, then you're done. The patient is considered a grade 2 or high aspiration risk. However, if the antrum appears empty, supine, you still have to evaluate the patient in the right lateral decubitus position. There's a clinical reason that you can turn the patient into right lateral decubitus, and you can lift the head of the bed 45 degrees, and that should give us a generally similar assessment. If you calculate the area and it is less than 10 centimeters, you should in general be okay. It doesn't matter what the calculated volume is. If you see the heterogeneous findings suggestive of a full stomach, your patient should be considered a grade 2 or high aspiration risk. And now for the severely obese patients. The depth is usually 7 centimeters instead of 3 centimeters. The area of the gastric antrum may be bigger, but it is still 1.5 mLs per kilo of ideal body weight. You can still use the qualitative and quantitative assessment models for the severely obese. And now for other special patient populations, pregnant patients and kids. You can apply the same assessment methodology to pregnant patients and children. Sometimes with kids, it may be easier for the kids to sit in a parent's lap, and you can record a video while you or the parent scans. Then you can go back and freeze the video when you see the proper alignment of structures and do your assessment. All right, so now it is time to test your nuts.
All right, so I think gastric scanning is really one of those things that's going to be a requirement for our clinical practice. When you guys come back in November, I encourage you to take some time while you're not in stations to kind of use the ultrasound and get comfortable with scanning each other for different things. I know you're going to have time in the lab with Maverick and some other stuff, but I think it's just really important for us to have these skills when we get out to clinical practice. And if you don't start developing them now, it'll be really hard when you're trying to learn 9 other things at the same time. The other thing is, while the step-by-step instructions may vary from one ultrasound model to another, the basic components are still going to be the same. You may push a different button, but it'll still be the same essential stuff. You're going to freeze the screen. You're going to measure this diameter of the antrum and make your decisions based off of that. So we're going to talk a little bit about preoperative evaluation for patients with obesity. It's primarily going to be focused on their existing disease processes and determining how extensive they are. So, what is their baseline blood pressure? How diabetic are they? What's their current A1C? What are they using for medication management? Looking at their cardiovascular status, are they in heart failure? Certainly if they're in acute exacerbation, we're going to put that case off for now. But how well controlled is it? And then specific things to think about, what hypoventilation syndrome do they have? And then what are they using to manage it? One of the things you'll see and that you may pick up from them is if they tell you they're on CPAP, ask them what settings they're on. One, because there's pretty high likelihood they're going to need it when they get over to recovery. But two, if they're on a CPAP and they've got a peak pressure over about 10, it makes you think that they're going to be pretty hard to mask ventilate when you get back there. So that's somebody I would probably consider maybe doing more of an awake technique because you're going to have a hard time ventilating them. Or if you were thinking about RSIing them, I would confirm that belief. Other things to think about, their current weight, potentially what their past weight was. Just because somebody's obese doesn't mean that they haven't lost weight. So figure out what their high weight was. If they've had any sort of surgical procedures that affected that, definitely ask. It could be something as simple as they had a Roux-en-Y gastric bypass, so you probably don't want to put an NG tube in them. Or, their increased aspiration risk because they've had a lap band done. They may be able to tell you a little bit about their anesthetic history. We get very hung up on patients being big and being difficult airways, and we certainly want to be cautious with them. But you'll see sometimes patients are big on the outside and not on the inside, and they're actually pretty easy intubations. But certainly don't be cavalier about your intubation attempts in this patient population. IV access tends to be troublesome. Very rarely do your veins stay superficial when you start putting on weight. So you may have a hard time getting IV access in these patients. The advent of the ultrasound has made a big difference, but at the same time, you're still going through multiple layers of tissue. So you may need like long IV catheters and stuff like that. Other things for you to think about, has the patient had surgery and where did they go afterwards? If they may not know exactly what their postoperative course was, but if they've had to go to the ICU every time they've had surgery, makes you think there may be a little bit more than what they're describing. And then finally, what were the surgical outcomes? If this is a bariatric procedure, how well have they done with it? Or did they have complications? They had clots, they were in the hospital for a long period of time, they developed pneumonia, that sort of thing. Other things to think about. What home meds are we going to continue? Usually we discontinue stuff. The ones you want to probably continue are going to be your antihypertensive and your glycemic agents. Most of these patients are going to wind up getting antibiotics because pretty much everybody does. Increased risk for DVT, so we want to stress some sort of chemo prophylaxis for these patients. And then the other thing to be cautious about, because we've talked about it several times, that they're at increased risk for aspiration. So just because of the increased aspiration risk or because you think they're going to be hard to ventilate, you may proceed with like an awake intubation or perhaps rapid sequence as opposed to kind of a long drawn out intubation. Other things to think about from an airway standpoint, they tend to have decreases in almost everything. Their vital capacity goes down, their respiratory capacity goes down, their expiratory reserve volume and FRC all go down. Their lungs tend to have very poor compliance. And when you look, you'll see that, especially when they're like laying down or like in a semi-recumbent position, their closing capacity is almost even with their tidal breath. So they're going to desaturate pretty quickly. So especially when you guys are first starting off, make sure you do a very good job of pre-oxygenating these people. The girl I was working with yesterday, like I said, did an outstanding job with everything other than her little antibiotics oops. But one thing I would make sure I do is give them as much pre-oxygenation time as possible. When I roll patients into the room, the first thing I do is hook up the pulse ox. And then while I'm doing everything else getting ready, I've already turned the oxygen on and I'm getting them to pre-oxygenate. This is somebody you probably want 5-10 minutes of pre-oxygenation and denitrogenation. Don't rush into these airways because even in perfect circumstances, they tend to desaturate pretty quickly. From an intraoperative standpoint, one of the biggest issues we run into is positioning. We're going to talk a little bit about specific things that you encounter. Other stuff you run into, airway management, we're going to talk about some things you can do to maximize your intubating ability and result in better outcomes for these patients. But there's also effects as far as like monitoring, make sure you have the right size blood pressure, choice of anesthetic technique. Perhaps we don't want to do a general anesthetic on this patient because we're concerned about their pulmonary status. Or perhaps we have to do a general anesthetic technique because we literally don't have needles that are large enough, long enough. We tend to alter our pain management strategies for these patients a lot of times because opioids are generally the hallmark of our analgesic approach, and they tend to cause respiratory depression. So you may not give somebody as much analgesics from an opioid standpoint because you're concerned about their pulmonary habits. And then the final thing you have to worry about, fluid management. Because these patients do tend to be a little bit larger, we know they have a larger volume of distribution. They may require more continuous fluids to maintain that. So we're going to talk a little bit about these positions, and then we're going to look at some examples of them. We're going to talk about some good things and some bad things because these are very challenging cases to position. So from a supine standpoint, because of the increased pressure on their lungs, they tend to be kind of difficult to ventilate. You'll also have compression of the IVC and the aorta just by the girth that's sitting on them while they're supine. In long cases or cases where patients are not well padded, there have been multiple reports of patients developing rhabdo in their gluteal muscles, which, you take somebody that's already got diabetes, hypertension, obesity, all those other issues, and now they throw in a little bit of rhabdo and renal failure. It's pretty easy to wind up with a mortality. Prone standpoint, you may see that when we turn prone, depending on the table we're using, that the cushioning pads may almost have the same effect on the anterior muscles that the gluteal muscles get from the kind of being supine. So you've got to make sure the patient's well positioned and you have enough positioning pads. Sometimes that means adding additional padding to the table over what's already there. And a lot of times what you'll see is even if you do everything right, you're still going to wind up with some degree of irritation and potentially breakdown for these patients. So you may consider having to move them around, especially kind of sensitive areas. Face is a big one, just because they tend to have increased body habitus in their face as well. You may want to just kind of move the positioning pillow around a little bit, and just be very cautious about things because they do tend to require us to kind of do stuff on the fly for positioning. You want to make sure that you're doing everything you can to prevent any sort of secondary injury. When you turn these patients lateral, a lot of times what we'll see is that dependent hip will develop pressure injury or ulcer. So again, it's very important to make sure they're well padded. We can put axillary rolls in these patients, but a lot of times, one, it's a strain for us, and two, it accomplishes absolutely nothing because they just absorb the axillary rolls. So you may see that there's no benefit in actually putting an axillary roll in place. With that being said, because of that increased body habitus, you may notice that their head is more elevated off the bed than traditionally. So you may have to have extra positioning pillows or padding underneath their head because it's a lot higher up off the table. There are a lot less complications doing these cases lateral decube versus prone. So if it's something that you have a choice, I would go with prone every time. Your other option, depending on what you're doing, may be to put these patients in lithotomy. Things you have to think about from that standpoint: traditional stirrups may not be adequate to support the weight. The stirrups may be physically too close to the table for the patient's legs, so your leg will wind up contacting the framework of the stirrup, putting him at risk for nerve compression. Other things you have to worry about, especially for long periods of time because of the increased body habitus, is there's a risk of compression of the tissue, ultimately resulting in compartment syndrome. All right, we're going to move on to some pictures. So this is not somebody that's super morbidly obese, but it gives you an idea of what you're dealing with here. So you have somebody that's turned lateral. They're already intubated, obviously. And you see how their girth has kind of shifted. There's limited padding on that downside. With the advent of kind of like some of the gel foam, like almost the posture or Tempur-Pedic kind of materials, I think we do a better job of positioning those patients now. Other things to think about: anything that's going to be kind of compressed or supported. So think about maybe like an EKG lead underneath the patient, or like a pulse ox or an IV cable. If you can remove it, remove it. If not, do your best to try and pad it. So you may be able to put it underneath that gel foam or whatever you have available. Same thing with straps on tops. The other thing you may have to consider is adding additional straps for these patients, because the one strap may not be adequate in the event the patient actually needs to be controlled with that. Another thing to be cautious if you're going to be doing any kind of extremes of Trendelenburg or lateral movements, be very cautious with these patients because your existing positioning devices may not be adequate to control the patient. This is an example of somebody in kind of a low lithotomy position, and this is a little bit more like what I'm talking about when we're dealing with a lot of these super obese patients. So you can see how close their legs are to the lithotomy stirrups there. That upper thigh is almost touching. They didn't have adequate restraints. So they've resorted to like almost like an ACE wrap type system to hold the patient on the bed. It may be better than nothing, but as you can imagine, when you go to court and somebody sees this picture and you ACE wrap the patient to the bed and then they fell off, you're not going to have a whole lot to stand on. So improvising stuff like that may not be the best solution. The other thing you'll see when you look at this patient is you notice there's going to be a lot of areas that are compressed. This patient already has some redness that's concerning for like skin breakdown. So imagine what's going to happen underneath that co-band that's holding him on the bed. This is what I'm talking about with the prone positioning. So you'll notice that the patient is essentially in between the bolsters. The cushions on the side are not doing very much, so they've had to pad along the rail of the bed to try and protect their girth. So increased risk for injury there. The other thing you see in a lot of these cases is that they just hang so low below the bed that it interferes with things. So a lot of times if we're using a Jackson frame like this, it's for neurosurgical procedures. So they're going to be bringing the C-arm in to try and get x-rays. The abdominal girth may get in the way for that. So a lot of times they have to kind of come in and go out from the top as opposed to the middle where they normally would. Now you're at risk for hitting the elbows. So just other things for you to think about there. This is another example of kind of a large patient positioned supine. They at least have the right straps for the bed, but you notice they didn't pad underneath the straps. The arms are too elevated. They're definitely well above 90 degrees. So now you're at risk for brachial plexus injuries. So just lots of concerns when you get into these patient positioning issues. Oops. Any questions about positioning for these folks?
Dr. Cornelius, you would prefer lateral decubitus over prone, or the other way around?
If I can. Prone is very hard to ventilate these patients. You'll see that when you're turning somebody prone, the biggest reason you wind up turning them back over is because of ventilatory problems. So if I can avoid putting them prone with their whole body weight on their lungs, I will. So first choice would probably be lithotomy, second choice being lateral, and then finally prone if I have no other choice. There's even some spine cases they're doing in a lateral position now. So yeah, that would be my choice.
Okay, thank you.
And I know you guys had some questions about the gastric scanning and ultrasound. We'll catch those after we finish everything else. Other things to think about as far as the airway itself, you tend to have increased adipose deposition into all the tissues. So the airway itself may be smaller. That may make things a little bit more difficult. You may also figure out that your traditional positioning is adequate for normal people, but when you start dealing with like obese or super obese, you tend to have to kind of boost things up a little bit. Predictors of difficult intubation, like I said, just because they're big on the outside doesn't mean they're big on the inside. So don't rely on BMI as really being the only independent predictor. Things that make me a little bit more nervous when I look at them and I can't get their mouth open. Like I had a lady yesterday, wasn't obese, but for a TMJ repair bilaterally, and she just couldn't open her mouth, but that's why she was there. It wasn't a surprise. But those are the things that make me a little bit nervous. You add to that large or kind of protuberant teeth. Especially like upper teeth, that makes me worry a little bit because now I've got a small mouth opening, plus I've got big teeth in the way. And then you add to that not a whole lot of neck mobility in retrognathia. It's almost like the perfect setup to make you really want to do something other than intubate this patient. So look at those factors. Don't rely just on a weight. And, the patient's 500 pounds. There's 500 pounds and there's 500 pounds, and it's not necessarily the same depending on the patient. So how do we kind of work to fix this situation? The biggest thing, like I said, is positioning our patients. There are a whole lot of commercial systems out there now, like the one on the right. It's called a Troop Pillow. And kind of a good reference point for you when you start looking at positioning your patient is you want the ear to be essentially even with like the sternum. So as you start bringing your patient upright, that's the position you're trying to achieve. There's lots of ways you can do that. You can use the commercial pillows. Most of the time, what I wind up using, even if there are commercial pillows available, is just going back to what I've always done, blankets, pillows. And then the other thing for you to think about, if you look at that center picture, almost every patient we encounter is on some sort of bed where we can just sit the head of the bed up. So what you're going to do is sit the head of the bed up, and then you're also going to have to do something to extend the neck out. But that may make your life a little bit easier. The other thing you have to think about for these patients, whatever we do as far as positioning, you may have to undo for the surgery. So like that lady on the left, if they're doing an abdominal surgery, they're probably going to have to take all that stuff out to do the case. Now, what'll happen on the back end is you'll move them over to the stretcher, and then you'll sit them back up over there for extubation. But it's just something for you to think about there. Maybe it's easier to pull one pillow out than pull out 10 blankets. I don't know. There are also inflatable positioning aids that you can use that you put into place, inflate them, put them in position for intubation, and then after that you can deflate them for the case, and then you can reinflate it for the surgery itself. So just know what you have available at your facility. And this is just kind of an example as what I was talking about as far as your patient positioning. So just try and align all those axes if you possibly can. So sit the patient up, extend the patient's neck. And like I said, a lot of times we think about putting stuff under the patient's head, but with these big patients, you're also going to have to put stuff under their shoulders as well. So at a minimum, consider sitting the head of the stretcher up, but at a maximum, you probably want to go ahead and do something on their shoulders and something under the head. So when we go back and look at what we can actually do, this works out very well in simulated patients. It also works out very well in real life. The other thing for you to think about is these patients are going to desaturate very quickly. And this is just looking at a desaturation to 90%, but normal patient taking 6 minutes to happen. These patients, it's half that time. And honestly, I think these are really generous numbers. Most of the obese patients are probably going to be desaturating in, 30 seconds for the truly obese patients. So on the back end, what do we do to try and prevent this from happening? So just like I said, sit these patients up. When we're pre-oxygenating them, sometimes I will go ahead and close the APL a little bit to like 10 centimeters. So I'm putting a little bit of continuous pressure on them. You can also consider putting them on CPAP or pressure support, whatever you have available. And then using that mask strap or somebody to hold that mask on their face. So they're kind of getting adequate expansion. Sit those patients up to allow the lungs to be kind of displace their girth. You may think about not just sitting them up, but putting them in true reverse Trendelenburg. Because when you sit them up, even though you're kind of increasing their oxygenation position, you're still going to be compressing those lungs against their abdomen. Whereas you put them in a true reverse Trendelenburg position, their abdomen's going to move as well. The thing you have to be cautious about with that is that you're not causing them to slide further down the table. So things to think about. We talked about, obesity is not really our only concern for aspiration. It's definitely a concern, but there's other factors that come into play. So which patients do we want to think about prophylaxis? Anybody that's got identifiable risk factors, so obese, diabetic, signs of impaired gastric emptying, use of any of those GLP-1 medications, you may want to think about doing some sort of prophylaxis. The most common ones we use are metoclopramide, and then we'll also do a lot of famotidine for patients. Just a caution, make sure they're being given well in advance. And with metoclopramide, you have to be very careful because it'll cause a lot of behavioral disturbances. Other things to think about, as I mentioned, if you're concerned about this airway, consider an RSI or an awake technique. Things to think about with regional anesthetics in these patients. They're certainly safe to do, but they may be challenging. Most of our experience is primarily based on obstetrics patients. Now, most patients, even if they're a normal body habitus before they become pregnant, will put on some degree of weight. So that makes it a little bit more challenging for you. So advantages of it, you can generally avoid their airway, but the last thing you want to do in a patient is back into a difficult airway. So if this is somebody you think you're going to have to do a general anesthetic on ahead of time, you probably want to start off with that, not have somebody that you've poked and prodded in their back for a while or tried to do a peripheral nerve block that didn't work out, and then you wind up intubating them anyways. Other nice things from a regional standpoint, you don't have to worry about the cardiopulmonary depression as much. There's a decreased episodes or risk of PONV. And they generally do better with post-op pain control without the concern of respiratory depression associated with the opioids. Now the bad news. These procedures are technically difficult. You need to have bigger needles. You need to have different ultrasound probes. A lot of times for our peripheral nerve blocks or spinals or epidurals, whatever the case may be, we're able to get by using the linear probe. Because of the patient's body habitus, you may have to go to a curvilinear probe, which doesn't provide you quite the same image quality. The nice thing is you can put in a little bit less medication into the epidural space because it's compressed. And more downsides, you tend to see a higher rate of block failure. And because of their abdominal compression of their great vessels, you tend to see more pronounced hypotension after the block itself. Things to think about from a monitoring standpoint, I mentioned this earlier, but make sure you have the proper size blood pressure cuff. We have this habit of not getting the right equipment and just moving it around to someplace it fits. We know there's a difference in variation from blood pressure on the upper arm to the lower arm, but a lot of times we'll still take the cuff that should be used up high and put it down on their wrist because that's where it fits. Make sure if you're doing a lot of large patients, you have the appropriate size devices to measure it. The bladder, the blood pressure cuff should go around at least 75% of the patient's arm. Other things that we kind of think about from an equipment standpoint, a lot of these patients develop pulmonary hypertension, so have a means available to assess it. Biggest ones being PA catheter or TE. As I mentioned, IV access can be very difficult. Sometimes these patients will require central lines, even for basic procedures. IV access with ultrasounds has helped some, but it has not eliminated the complexity of it. Because they are high risk for DVT and PE, a lot of times they're going to go on chemoprophylaxis, but you may need, especially in some of these patients that are going to be in the facility a long time, they may need to have an IVC filter placed. Other things to think about, if you're putting an arterial line in this patient, again, you may need longer catheters. So traditionally, when we put in an arterial line, we use just that little 20 gauge arrow dart that's kind of like an IV length. You may have to put a femoral sized catheter into somebody's wrist just because there's a lot more body habitus there. From an anesthetic standpoint, there's really nothing favored one way or the other. Like I said, just be cautious about backing into a difficult airway with these patients. A lot of our sedative medications will result in an exaggerated response, especially in patients that have existing sleep apnea. So be cautious with longer acting medications. You will also see that things that result in prolonged sedation may not be so great for these patients. Usually we want them pretty awake on the back end of the case to protect their airway, to breathe, because they didn't do those things very well when they were asleep, or excuse me, when they were awake. They're definitely not going to do them while they're sleepy. So be cautious with like Benadryl, dexmedetomidine, some of those medications that'll cause prolonged sedation. Other things to be cautious of, make sure they're fully reversed, because they will lose that muscle tone not only in their airway but also in their pharyngeal muscles. Other things to think about, your volatiles tend to make them not respond to CO2 changes quite as well. So we may not use quite as many volatiles on these patients. On the other hand, propofol tends to stick around longer, especially in somebody with that large volume and distribution. So that may be less than ideal as well. We generally will not do wake ups with nitrous in this patient population because they require quite a bit more oxygen. That doesn't mean you can't use nitrous during the case. You just want to make sure it's gone before the wake up. These are just some examples of things you dose based on ideal body weight and total body weight. With that being said, a lot of times we assume that the patient's not going to be compliant with whatever medication we give them. So you can start off at the lower dosage, just make sure you have the higher dosage available. From a volatile standpoint, we usually use desflurane for these patients, but you'll see after you have a longer case, generally more than about 2 hours, that it doesn't really matter, because at that point, the gas has become so saturated in the tissue that it's going to take a while to come off. Other things to think about from an anesthesia standpoint, know the appropriate weight for your operating room tables. As we're getting to larger and larger patients, you may see that you can only use certain tables because the patient has exceeded that weight. Try and avoid doing sketchy things. I know that seems kind of basic, but you will see pictures of 2 OR tables strapped together, or putting things into places they weren't intended to. Tape is great, but tape should not be the solution to not having the right equipment. You'll see that in this patient population, a lot of times we're taping stuff together because we don't have what we really need. So if you're going to do a lot of these cases, try and make sure you have the right equipment. Because they do have a larger body habitus, they have more exposed tissue to become hypothermic. So make sure you're appropriately managing their temperatures. Other things to think about, what are we doing with arms? Sometimes the arm boards are not strong enough or big enough to hold them, so it's somewhat common to have multiple arm boards beside each other. You will also see this little clear plastic piece here is called a sled. Oftentimes it's used in like the cath lab or interventional radiology to hold the patient's arms in. The patient may be too big for that. So you may have to get the bigger sled, or you may have to do something to make sure they're well padded with the existing sleds. We know that they've got increased fluid requirements because of their increased body habitus, but make sure you're paying attention to that. The other thing is we tend to see a little bit of a decrease in response to volume administration. So pay close attention to how responsive they are to fluid status as well as other medications. On the back end of things, like I talked about earlier, sit these patients up. Usually you're going to sit them up before extubation. You may even consider putting in like an oral airway or 2 nasal airways and an oral airway before you extubate them, because you know they're going to obstruct, especially patients you know need to be on CPAP, BiPAP, what have you, because of their OSA. Make sure they're fully reversed. It seems like something kind of silly to say, but make sure they're fully reversed from any sort of neuromuscular blocker. Almost all the facilities I know of that have any sort of criteria limitation for the use of Scamadex have okayed it for obese patients. You may see that these patients do really well waking up on pressure support. The problem you run into is we'll do a good job of ventilating these patients during the case, and then when we go to get them breathing spontaneously, things kind of fall apart. We let their volumes drop off. They almost instantly develop atelectasis. So consider moving these patients to a pressure support mode as they're waking up, as opposed to just giving up whatever you had. As I mentioned earlier, consider either having their CPAP or BiPAP available or having respiratory in the PACU ready for it, because they're probably going to require it, even sitting up. Other things to think about: low opioid or opioid-sparing techniques, medications that don't have the degree of respiratory depression. And I put dexmedetomidine there because it's something to consider. You just have to be very cautious when you're giving it that you don't get to the point of heavy sedation. If you're using it in lieu of something that may be worse, like heavy opioids, it may be better, but high dosages may be problematic. And then the final thought for this is, especially when you guys get out into clinical practice on your own, think about when and where these cases are done. There are small facilities, whether it's an office-based practice or like a critical access hospital, that you probably shouldn't be doing some of these cases. They need to go down the road to a larger facility. The other thing is the time of day these cases are done. You'll see that facilities tend to manipulate the schedule based off of what's convenient for the surgeon. Sometimes they start off with like the easy, quick cases, and then by the end of the day, when there are less resources around, that's when they start doing the sick people. Same thing happens with these really obese patients. They didn't get done when they should have been, and now you've got a diabetic, hypertensive, obese patient that's been sitting there for all day. Their sugars are all out of whack. You've got less help to move the patient around. You really need to make these kind of cases a priority when you're thinking about scheduling. All right, that's about all I have for that. I'm going to flip back to the questions you guys had about like the GLP-1 medications first. Megan commented about her experience taking one of the medications for polycystics. And they result in great weight loss. And I think after people kind of figure out how to control the side effects, they do pretty well. So I think part of it, she was asking because they scanned her stomach when she was here and it was empty. I think part of it depends on the dosage. Part of it depends on the medication. Part of it depends on the diet that you continue and then your duration of action. Patients that I think lose weight and do really well with them tend to adapt their diet to the medication regimen and how it impacts them. Patients that continue eating like they were before are basically forced into stopping. So I think that may have something to do with it. Some issues with the video. You guys are welcome to go back and watch that video again on YouTube. And then, like I said, when you come for symposium, if you got downtime, you can grab one of the ultrasounds and play with. Stefania asked about once they stop the medications, did they get their normal gastric emptying back? We think that they get their normal gastric emptying back in about 7 to 14 days, but that hasn't been real well established. One of the issues, and I think one of the things that hasn't been really well explored yet, is so these patients take medications, they lose lots of weight, and then they stop taking it. Have they kind of retrained their brain and their GI system so they don't gain the weight back? You'll see patients that have bariatric surgeries that will go through and gain weight back, especially if it's something that's kind of defeatable. So think about like a, like a lap band. I know lots of people that have had a lap band done that either wind up taking volume back out or having it removed. The permanent stuff like sleeve gastrectomy, Roux-en-Y bypass, those tend to have better outcomes because the patient control factor is kind of eliminated. Mo asked about what medications to use. Yeah, primarily non-particulate antacids and the different antagonists. The one caution, as far as like non-particulate antacids, is they're disgusting. So I generally avoid them in anyone I can. They're really only the standard for OB patients. So I tend to just use IV stuff in this patient population, but that's just my experience. The book answer is probably still to go ahead and give them the non-particulate antacids. It's just, like I said, in my experience, that almost results in more trouble than it's worth because they've been nauseated already. And then he asked about Reglan affecting the metabolism of sucks. I use rock in the high dosage for everyone. So when you start looking at medications, and part of it's going to be regional variation, part of it's going to be a cultural thing for wherever you go. Some facilities still use sucks for everything. With the advent of Sagamidex, I really backed off who I was using sucks on. About the only time I will use sucks is I have someone that needs to be endotracheally intubated, and there's a contraindication for sucks. So maybe like they're doing neuromonitoring. In some of those patients, I will still use rock and then just reverse it immediately with Sagamidex, just because the side effects and the ill effects from sucks are so high. Other places you go, they use sucks for everybody. And then if they need long-term paralysis, they'll move to a different agent. My personal feelings are when I can give one medication and accomplish the same thing and avoid all the bad things that come with sucks, I'll probably do that. Some people will tell you that sucks is safer because the patient's going to come back breathing faster. The reality of the situation and what research dictates is that it doesn't matter. The patient's going to desaturate either way. So, Miguel asked about Maverick, and I had an email from them that they sent while I was talking, and I didn't get to look at it. So let me look real quick and see what Dina had to say. She said that the director of operations is going to be contacting me either today or tomorrow to provide all the access instructions, and he'll help me out with any sort of technical issues. So I guess we will get our Maverick access either today or tomorrow. Sorry for the delay. You guys will definitely enjoy that. And if you have any questions after you get that, please let me know. I don't know if he'll send out an announcement to you guys or if I'll just send out another one, but I'll get that out to you as soon as I can. All right, any questions about anything else?